Good morning. Thanks. Good morning.
Good morning.
Okay. Thanks for the invitation to be here. Courtney, thank you for your work and for the introduction to the other panelists. I think Dr. Knickman did a great job of walking through the requirements that we have, what the schedule is. I'm reminded of, I haven't seen this in many, many years, when my children were preschool. They had this thing on Sesame Street where one of these things is not like the other things. And I would be the one that's not like the other things. I began my career in insurance about 3 years ago when I was named chairman of the insurance committee in the state assembly. I'm not a healthcare provider. I'm not an attorney. The first day on the insurance committee was the day I was named chair, so I hadn't spent any time in the insurance committee. And I thought this was going to be a relatively easy assignment, and then along came federal healthcare legislation and reforms. So this has been fascinating, and I'll just take a few minutes to give some thoughts on some of the issues that we're dealing with in light of what Dr. Knickman has outlined. And we do have a great deal of work to do. A lot of it will be led by the state insurance department. We'll have the regulatory responsibilities and also by the governor. For instance, the governor has submitted, I think just a couple of months ago, notification to the federal government relative to the risk pools and the decision by the state to construct a response to the federal requirement as opposed to having the HHS do that. So the governor is taking the lead on some of those issues. But let me just mention a couple of thoughts that I have. First of all, it's clear from the outline that Dr. Knickman proposed or suggested that New York has really led the way on a whole host of issues that the federal government has put in its legislation. In many ways not identical to the approaches we've taken, but many of the issues that we've tried to adopt over the years in our efforts to try to get to comprehensive affordable care. And while there are 2.7 million New Yorkers still uninsured, obviously programs like Healthy New York and some of the other programs that we have, which are not for people who do not meet Medicaid eligibility, are New York's way of trying to address some of the concerns that the federal legislation embodies. Last year, I think it was last year, my memory is not so good, we did legislation to allow people up to the age of 30 to be included on family health policies, although we did it in a different way and it's more conservative than the approach taken by the federal government. But nonetheless, that was a part of the population that we felt had particular needs as they were transitioning from school to work, and typically first work assignments don't include the full range of benefits. So we addressed that last year. We passed some managed care reforms which provide additional rights to those individuals who are in managed care programs, et cetera. So New York, in many ways, has been trying to address some of these issues, not obviously in the same way, nor is it as comprehensive. We're obviously, as a result of federal legislation, not able to mandate many of the services we require on typical or commercial policies to the self-insured population as a result of ERISA. So this will have the effect of creating uniformity. And so that's a very positive development. There's a lot to this, as the doctor rightly points out, and some of it is just difficult trying to get your head around and understanding what the timeline is, what the implications are of what you do, and how what you do may be inconsistent with existing state law, and so how do you conform to that. I do want to just talk a minute or two about the legislature's work, and then and talk a little bit about cost containment, and some, perhaps just some observations on federal funding, state funding, et cetera, and sort of the political challenges that we face. One thing, as it relates to the legislature, we will take a lot of the cues that we have on implementation from the executive, as I indicated, as well as from the state insurance department. I intend to convene a hearing probably shortly after the start of the end of the legislative session to encourage, as strong as we can, the state insurance department to come in and fill us in on details of the implementation plan as they see it. So as we're working through this, we've been certainly encouraging their dialogue with the legislature. Frankly, we haven't gotten much back from the state insurance department yet on their plans, but one of the things that we will do is monitor them very, very carefully, and we will begin that process by holding a hearing, which we will ask them to come testify on what their plans are, where they are in terms of schedule, what their timetable is and what implementation will be required by the legislature. For instance, the high-risk pool, I think has to be implemented by July 1st, and we have not seen a bill forthcoming from the executive or the insurance department yet, although the governor submitted to HHS the indication that the state will take on this responsibility. So the time frame is pretty narrow. So we're concerned about that. We want to make sure that while much of this is regulatory in nature, there are some significant public policy issues that still need to be decided. And in doing that, the legislature has to be a full partner in those conversations, and you're going to find many legislators with various opinions on these subjects, as is often the case. And I do want to talk, before I get into sort of some of the things that I think we need to address relative to cost containment. One of the observations I would make over the last 3 years has been the sort of whole issue of how to balance in all areas of insurance, but perhaps in health insurance more acutely than others. How do you balance the various competing interests? This discussion, at least on the insurance part, forgetting for a minute the broader health issues that we need to deal with as a society, but on insurance issues, it's often posited as, look, we can have comprehensive coverage and everybody can be covered and we can keep costs low if we could just tame the big bad insurance companies who are putting all their profits and making all these profits at the expense of consumers. I think that's probably been sort of imprinted on a lot of Americans' minds, and so you sort of see a lot of the at least from political people, elected people, probably not so much policymakers, the sort of almost instinctive button they press to talk about the insurance lobby and insurance companies, et cetera. My observation is there's a lot more nuance to this. For instance, many members of the legislature will, and this time of year we're sort of dealing with this, will advance proposals to increase coverage by mandating X or Y or Z. Sometimes it's mandating certain diagnostic tests. Sometimes it's eliminating co-pays, or it's taking utilization reviews off, et cetera. And the notion is, well, the insurance companies will just pay for it, as though there were no consequence as it relates to premiums or rates, et cetera, as though that those two things were completely unconnected. And obviously that's not true. And so what we've done, for instance, in the last 3 years that I've chaired the committee in the Assembly, excuse me, we have not added any mandates to insurance policies. Our view is that making policies more comprehensive is wonderful, but if the offset is that it raises the cost of premiums and rates and makes it unaffordable to people on the bubble who are almost at the point of not being able to afford comprehensive care, that's not a particularly reasonable, thoughtful, or appropriate and responsible thing to do. So we've been very, very careful about trying to create that balance, and I think we need to think of it more in terms of that balance. What coverage will there be? And the exchanges are obviously directed towards trying to have greater creativity, have different levels of care, but I think we will see products that aren't currently available, obviously, in the New York market. So we have to balance coverage and cost. We also have to look at whether we're going to do pooling. Every single day I get approached by someone who wants to essentially pull out of the community-rated system. For instance, I was approached recently by small municipalities who have fewer than 50 employees. And the way they first described it was, we have special rules which don't allow municipalities with fewer than 50 employees to come together and be experience rated, and et cetera. And after you talk through it for some time, you realize what they really are just describing is there's no special prohibitions on municipalities. There's community rated system. And so to the extent that they want changes in the law, what they'd like to be able to do is be experience rated. So as we're sort of looking at this, the question of whether or not we're pooling like individuals, whether or not there will be community rated systems, or whether or not everyone will be experience rated, obviously to the extent that you pull good risks out, as you pull people who are healthy and well out of a system that's community rated, what you leave behind is people who are sicker and who are going to pay a higher rate. So that's all a part of the public policy, but every day there are ideas. And you can see the allure to doing this, that people would say, well, small municipalities group together, they become experience rated, it's going to drive down the cost of property taxes because those municipalities will have lower insurance rates. What they don't think about, most legislators who aren't dealing with this on a day-to-day basis, is, yes, that's true, you pull all those good risks out, what you're left behind is with rising premiums for the population that remains behind. So in order to address that, I think we have to do a much better job, and perhaps the foundation could partner with us on public awareness and public education, but perhaps we could start with just legislators and policymakers as it relates to some of this balance and some of the unintended consequences of some of the decisions that legislators and other policymakers would like to make. So I think that's it's certainly been a part of the learning curve that I've gone through over the last several years, and it's something that I think we all need to be mindful of as we make some significant changes in the way that we're going to deliver health insurance and health care in the United States. I would just finish by saying this. I think there's still far too little in the federal legislation that relates to cost containment and the drivers of healthcare costs. And I find this sort of fascinating, again, because I don't come to this with any real preconceived notions as I accepted the role as chairman of the insurance committee, that we do an awful lot in the world to try to paper over some really difficult problems. So we do, for instance, in a completely different venue, put a property tax cap in place because we really don't want to address what's driving property taxes higher and higher because that's too painful. So we put like these artificial caps and then sort of hope that somehow in the alchemy of all this it will work out. And I think that's part of what we've done in health insurance. Last night, for instance, both houses of the legislature reinstated something called prior approval in New York State. So from this time forward, starting October 1st, we will have prior approval of all healthcare products, all insurance products in New York State by the state insurance department. Now, there are those who think that's a very good policy. I have probably more ambivalent feelings about it because unless we're prepared to really address the cost of health insurance and why it goes up, simply putting downward pressure artificially isn't going to address the concerns that we have. And so I think we really have to focus on that. One of the other things we did coincidentally last night, the same bill has raised the MLR to 82% for small groups and individuals, which is, I believe, higher than the federal legislation, which will have an 80% MLR, and we're awaiting definitions from the federal government on that, so we will no doubt, or at least hopefully, be consistent with federal law. But as Dr. Knickman talked about, obesity, hypertension, diabetes, chronic disease, we have to do a much, much better job at being able to address those concerns. Preventive care, greater consumer awareness and education about lifestyle choices. And this is really a significant issue. I'm pretty proud in Rochester, New York, the business community has seized on some of these initiatives and are working very, very hard, putting a lot of skin in the game to try to change community outcomes. They have a goal of being the healthiest community in the United States in the next 20 years. They're working very hard with corporate leaders to try to do that, and they're addressing chronic healthcare problems as a way to getting not only to lower costs, but to healthier, better outcomes. And we need to clearly focus on that. Some of the other things that we're hoping to address, healthcare planning. This deals sometimes with the physical structure of our healthcare systems in New York. And again, in Rochester, we have something called the Finger Lakes Health Systems Agency that reviews certificate of need requests. It has done a great deal in terms of bringing the business community, the private sector community, and not-for-profits, as well as the healthcare community together around healthcare planning and right-sizing the healthcare system for our community. That's something that I think needs to be done all across the state. Obviously, the doctor mentioned medical home, which is something we need to continue to put dollars into and to encourage electronic medical records, which I think can really have the effect of limiting the confusion that sometimes results with different providers and the same individual. The use of telemedicine and telehealth, which we're continuing to try to advance, and I have new legislation which will create essentially a cabinet for telemedicine and telehealth in New York. There are many things that we need to do, and we can't simply say that we're going to address the insurance pieces, but not really address the cost drivers that are making Americans less healthy, driving up costs, increasing diagnostic care, diagnostic testing, and all the issues which go so much into raising rates. And the last thing I'll say is the one point I might find some disagreement on, and I'm not sure the doctor is wrong. The federal government, the question of whether or not they're going to help pay for this or not. I think you're going to find the federal government is going to have to step up to the plate. They may be bankrupt, but they have the one advantage over the states in that they can print money, and they seem to be willing to do it. And I think without regard to what happens in the midterm elections, many states are facing the great challenges that New York is facing. Some much more acutely facing it than we are. And I don't know that the federal government, having staked its reputation on this and gone so far to the limb, I don't know that they can afford to allow states to have to pick up the implementation without somehow being able to help fund this. So I don't disagree that they may be cash strapped. I think the problem is they're going to be less cash strapped in the sense than the states are. And since this is a great federal initiative, probably certainly the beginning of this century, and the most profound change in healthcare legislation, I don't think they can avoid responsibility for helping implement it. So thanks so much for the invitation to be here, and I look forward to questions.